السلام عليكم ورحمة الله جميعا. مساكم الله بالخير والصلاة والسلام على رسول الله. Thank you very much for this introduction, and thank you very much everyone. Today's session and panel discussion is about strategies in reducing diagnostic errors in clinical practice. We're going to shed a light, inshallah, today about a lot of the achievable methodologies, whether cognitive or systematic, in an enriching discussion that improves reducing these strategies to reducing clinical errors. We have now attended two amazing lectures by Dr. Wazzan and Dr. Al-Khaf'ami, and we've learned a lot of it. And I am personally looking forward to learn from our colleagues and friends, Mr. Luqman, Dr. Khalid, and Ms. Leslie. I'm very excited to have this discussion with you today, and hopefully we're going to enjoy it all together. Now, to start with, what we're going to be doing is we're going to segregate this into different aspects and topics. So we're going to start with a discussion, dear colleagues, about the common sources of diagnostic errors. So I would like to start with a question, if you might be. What are the most frequent causes of diagnostic errors in daily practice? And maybe Dr. Khalid, you would like to start the discussion?
Thank you, Dr. Haitham, for this introduction. I would like to thank the Saudi Patient Safety Center for inviting me here. And I'm very glad and happy to join in this amazing opportunity. Diagnostic error is actually a big concern to me myself as a person, and it's a big concern, I think, for everyone in this room. So let me go a step back. So I want to simplify the definition of diagnostic error. So this is the most important thing, because this is what I have learned like 20 years ago. So simply, the definition is basically, if we are missing the diagnosis, we wrongly diagnose the patient, or we delay the diagnosis. And this is the simple definition. But there is another component, which is the next level of the definition. If we know the diagnosis, but this diagnosis was delayed to be communicated to other parts who is responsible, or healthcare providers, to take care of that action. So once we understand the concepts, so it's a broad spectrum of aspects that we should focus on. So looking back to your question about the sources, there are many, many sources during our practices. In our practice, we are facing, like we are working in a high level of high or busy services, and these kind of services urge us to do many things. So if I will talk about the source, let me give you a story, why I am here. So, like in 2007 or 2006, my cousin, Bader, he was like 34 years old, adult healthy. He visited emergency department, okay, with left-sided chest pain, radiated to his shoulder, okay, and that was in about 2:30, which is the mid of the day. And he was examined, and they did for him ECG, and they did for him some blood work, and they said, this is only muscular pain. And they asked him, he said, I was playing volleyball yesterday, and maybe this is related. So here, the problem started. Then they discharged him home. 12 hours later, Badr complained of severe chest pain, shortness of breath, and he was almost gasping. Ambulance take him to the hospital, and he died. So this is a very sad story, and there is lots of things, the sources, if you can see, where can we find this error. The other patient, after 2 weeks from that, so I have a double head. I was doing my residency. I see my patient. He was 28 years old. He had femur fracture, operated. Second day, he was complaining of shortness of breath. And again, we are preoccupied with things. We send them for a CT scan, spiral CT. They said there is no PE. They said just continue same treatment. I asked my consultant. He said mobilize the patient. And unfortunately, the same night at the night, he was passed away. So these two things, if you look at it, this is the sources. So the source of these kind of events can be during our initial assessment, where we are preoccupied with bias, and maybe we are not dealing with the patient or taking appropriate communication with the patient. During the communicating tests and diagnostic assessment and consultation, or maybe it is delayed. So These are three phases that could be a source, and there are many other sources of this kind of
Mr.
diagnostic error.
Luqman, yeah, thank you very much, Mr. Luqman.
Assalamu alaikum. Good afternoon, all. First of all, I'd like to really thank Saudi Patient Safety Center for facilitating this and having me with you here today. Actually, pertaining to diagnostic error, whenever you are going through literature and research, you will figure out that it is 10 to 15% of the adverse and preventable event is because of diagnostic error. And whenever you go through the theme or thematic analysis of what caused this diagnostic errors, you could go for the first cause, which is that the physician is or failure of physician to order the proper test for the patient. And the second could be that the physician did not follow on critical and panic result. If you will go to ER example, you will figure out that the main cause of this diagnostic error is the time pressure that we have in that specific area. So doctors tend to rely on their anchoring bias, we call it, which is first impression. They don't complete a thorough medical assessment for patient, and they go after their, initial impression and treating the patient accordingly. And this caused really, in research, 34% of patients who was treated based on this anchoring bias reflect that there is a failure in treating the patient properly.